Introduce Dr Rachel Clarke as our guest speaker today. Before I do an introduction, I just want to remind you all that there will be an opportunity at the end of the presentation for a discussion, so we can sort of save all questions until Rachel's finished. And there are some refreshments afterwards where we can all sort of mingle and get to know each other a bit more if there are any questions that you have to ask Rachel afterwards. And if you're on Twitter, do feel free to tweet through the event with the hashtag MCPCRD. That's something we don't really use that much. So it gives great pleasure to introduce Rachel. Rachel's a palliative care doctor. She's published 3 non-fiction books about her experiences as a doctor, all of which are the New Content Service. Just throwing that out there. Previous to her medical life, Rachel was a broadcast journalist with an interest in current affairs, producing and directing documentaries about Palliative as one example of what she did. Today's presentation, as you can see, is called Palliative Care in a Pandemic, Professional, Personal or Political. And during this presentation, Rachel will discuss her experiences firstly as a palliative care doctor. She'll discuss the provision of care during the pandemic to people who are dying, and she'll discuss some of the national and international stories that unfolded during that time. So I won't take any more time introducing Rachel.
Well, thank you very much for inviting me. It's really great to be here. Can you all hear me okay?
Yes.
Very good. I feel like I should start with 2 apologies. So one being there is no academic research or credibility at all in this presentation. It's quite a personal presentation. And I think I thought it might be really interesting to reflect on everyone's experiences of the pandemic in a kind of broader sense. And my other apology is for anybody who was at this year's APM Congress in March. This talk is based on a talk that I gave there, in as much as I've sort of been, ever since giving that talk, I've been reflecting on this topic, and I want to keep thinking about it more. So apologies if you have been, some of it, but not all of it, will be familiar. But the reason I'm very interested in this question of personal, political, and professional spheres of our lives during the pandemic is because I think that during COVID-19, those 3 worlds collided in a way that is certainly unprecedented in my lifetime and probably all our lifetimes. And somehow, in a global public health crisis, which is what COVID-19 was, and you could argue remains to a significant extent, the political became very personal for people who were bereaved, who lost their lives, for instance, and also professional. Everything that politicians said and did had an impact on how the pandemic unfolded, how it was managed. And so I think all of those worlds became sort of very intimately bound up in one another in ways that were interesting and challenging. And I, as Nicola has just said, I became a doctor after having a previous career as a journalist, and I sort of came into medicine with this very strong belief in the importance of enabling people's stories to be told, to be heard truthfully, because testimony matters. And I was horribly conscious of that all the way through COVID. And I think, just lastly, by way of introduction, I imagine we've all got slightly different reasons for deciding to work in palliative medicine, but I know for me personally, it was significantly because within the broad group of patients, all of whom you could argue are to some extent a vulnerable group, it is disempowering, it's difficult being a patient. There are some groups of patients who are more vulnerable than others, such as people with disabilities, with mental health problems, and palliative care patients are very often a very vulnerable group, and their voices, their stories are not always heard. Sometimes they literally cannot give voice to their story, and they're easily overlooked in a clinical environment, especially a very busy hospital environment where they're frail, they're unwell, and they don't necessarily have people sort of advocating forcefully on their behalf. And I really wanted to work with this group of patients for precisely that reason. That was one of my strong motivations, because I hate to see patients being overlooked. So first of all, and I don't have a clicker, so I'll have to hover here. I suppose this is the sort of archetypal image of the pandemic. These are two ICU nurses, and they're in their full level 3 PPE, and probably for most of the public, they will think of the pandemic as an ICU-centred phenomenon in hospitals, because ICU medicine in the pandemic was the most visual, it was where all of the journalists wanted to be, it was where we saved lives with ventilators, and of course we all know that the vast majority of the dying didn't take place in ICU, it took place in ordinary hospital wards or in care homes or patients in their own homes, and it didn't always look like this. And that leads to a fundamental question around whose stories are heard in a pandemic and whose stories are marginalised or sort of pushed to the edges or silenced or ignored, both patient stories and also staff stories. I think stories are at the heart of good medicine. I love this quote from Philip Pullman. I think it is absolutely true in a hospital, even in a busy A&E department. I think it's true. I think if we don't centre our patients' stories, the narrative of their unfolding life in what we're doing, then we're not being the doctors perhaps we should be. We have to have our patients' stories centre stage, and probably nowhere is this truer than in palliative medicine, where if you are given a life-limiting diagnosis, suddenly your story of your life, your personal biography, is completely disrupted. You imagined you were, in theory, mortal, but perhaps would just live forever, and then suddenly you're brought face to face with your mortality and having to confront all the loss and challenges that go hand in hand with that. So I'm interested in stories in the pandemic and whose stories were heard and not heard and why, and the role that we as doctors should have, could have, in order to enable patient stories to be heard. And that's what I'm going to talk about today. So, I thought to begin with, right back to basics, what is a story? And to illustrate the answer to that question, I've got a couple of really beautiful, succinct stories. So the first one is from John le Carré, and he was asked in an interview in the New York Times to define a story, and his answer went like this. He said, well, the cat sat on the mat is not a story, but the cat sat on the dog's mat, that definitely is a story. And another really beautiful story comes from Ernest Hemingway. I'm not actually sure if he really invented this story, but according to literary legend, he did. And back in the 20s or 30s, supposedly, he came up with a beautiful 6-word story, and it's an early example of what's now called flash fiction. So flash fiction is a type of writing where you write a story in a predefined, very short number of words, and in this case, 6 words. So there are whole books of 6-word flash fiction stories, but this one is from Ernest Hemingway, and it goes like this: for sale, baby shoes never worn. Beautiful story. And I thought, just for a third example, I would quickly tell one from my own experience in palliative medicine. So this is a former patient of mine called John Carberry, and I'm telling his story, showing his picture with his consent. And John, don't worry, John came into our hospice with that tracheostomy in situ. He had a laryngeal cancer. He had to have that tracheostomy fitted pretty much on diagnosis. He'd had many respiratory arrests, and he ended up being rushed into our A&E, and from A&E to the hospice. And he had been hemorrhaging through the night. So when I arrived in the morning at work, I was told in the morning handover that he was very, very unlikely to survive. No one had even expected him to survive the night. So I went off to see him on my ward round, but there was a priest hovering just outside his door. So I thought, oh my goodness, okay, so maybe he has in fact already died. I went back to look at his notes, and there was this amazing letter from his oncology consultant in the notes that referred to John from a few weeks earlier, and it said that he was delighted to see Mr. Carberry, who was a very impressive man, and he was in his 90s, John, and he was impressive because he still insisted on cycling to his oncology appointment. So Oxford is really, really hilly, and the hill to go, you have to cycle up to get to the cancer centre. I don't like doing, and I'm not 92 with tracheostomy, but this is what John did. And on this particular occasion, he had been knocked off his bike by the wind, but as the consultant said, he simply brushed himself down and carried on to his appointment. So I read this and thought, gosh, he's an incredible man. And when the priest had departed, I established John was still alive, went in to see him, and I was really surprised because I thought I was going to see someone who was essentially moribund, but in fact, he was sitting bolt upright in bed, as alert and alive as he looks in that picture, but not as happy. He was very, very angry indeed. And his speaking valve had been removed from his tracheostomy tube, so he couldn't speak at all, and he was furious, and he was gesticulating like this. And I didn't know what was wrong with him, but one of the nurses said, well, he had been promised a drink when he arrived, and he wanted a whiskey. We had a drinks trolley in the hospice, and he hadn't got it because the team had been supporting him as he hemorrhaged from his cancer. So we handed him a bit of paper, and he was very keen to write a message to me, and I thought, gosh, he's going to write, maybe this is going to be some really moving final words for his family, something really lovely, and I'll be very honoured to pass it on. He wrote in capital letters, just like Donald Trump tweeting, he wrote, "Where's my bloody whiskey?" And that was it. He didn't die. His hemorrhage had stopped. He was a delightful man. And the best thing we could do for John was this. So his favourite thing was pink gin and lemonade. So we found a bottle of pink gin in our drinks cupboard. And every lunchtime he'd have this pink gin. And that gin was a symbol for John of not everything he was as a human being, but what he loved and relished about life. He knew that he was dying from this horrible tumour. He knew he didn't have long to live, but he just celebrated having that pink gin every lunchtime. And the act of us giving him his pink gin, it wasn't medicine at all. It was a way of saying to him, you matter, and your appreciation of life is important, and we as your caregivers, as your team, are going to try and support you as the human being you are, irrespective of your diagnosis and your prognosis. And that, to me, seems like a really important type of story that we try and build with our patients in palliative medicine. So I think stories matter in medicine because the way we understand a human life is not in terms of sort of simple cause and effect. We are not Newtonian apples falling from the tree. We are human beings who understand our lives in terms of meaning and value. So the things that drive a human being are not mechanical forces. They are things like ambition, love, selfishness, kindness, avarice, magnanimity. All of those values are what drive us and what give us our meaning in life. And somehow medicine needs to find a space to embrace all of those. Does it matter if stories around medicine, death and dying are told with the active participation and voices of doctors, of our profession? And to answer that question, I want to use an example briefly before we get on to COVID, which comes from America. And this is the example of these charming people in the States. So this is an advert from the NRA, which is the National Rifle Association in the United States. So a very unpleasant organisation who on their website literally and with no irony describe themselves as America's oldest civil rights organisation because they are championing the constitutional right of Americans to bear arms, but actually, of course, they're an incredibly powerful, incredibly well-funded organisation devoted to the rights of gun owners and the profits of gun manufacturers. And there's a really interesting example of how doctors clashed with the NRA from a few years ago, which started when the NRA put out a tweet. And this is a headline based from that tweet at the time. And this is the tweet in question. So the NRA objected to doctors producing academic, peer-reviewed research in respected journals that examined and investigated the public health harms of gun ownership in the States. They took issue with doctors having the temerity to investigate and talk about that. And essentially here, as you can see in the tweet, told doctors to get back in their lane, which was an extraordinary thing to tweet and predictably incurred the wrath of the medical profession. So everyone started tweeting, and these first couple of tweets, so these are both from American emergency medicine physicians showing graphically the impact of guns on patients in their A&Es. And then this tweet is from, this is a forensic pathologist who's based in San Francisco, and it's a very angry tweet, you know, the language is angry, and she was interviewed after this tweet, which was shared over 300,000 times. And when she was interviewed, she said, "I was angry because when I saw that tweet, I had just finished an autopsy, and it was the second autopsy of a gunshot victim that I had performed that week in San Francisco." So she took immense exception to anyone from the NRA telling her to stay in her lane when clearly her lane and the lane of all these other doctors was the catastrophic impact on patients of guns in America. It's an interesting example of a phenomenon which I think we sometimes forget we possess as doctors. It's really easy in medicine, especially in the NHS at the moment, to feel hopeless and helpless and as though, you know, the whole NHS edifice is crumbling around us. But we have more power, I think, than we remember, and it's illustrated in this slide. So every year, the polling company, Ipsos Mori, run this poll, and it's called the Veracity Index, and they ask a sample of the general population how likely they are to trust each of these professions. And you can see that nurses and doctors are right at the top. This is the first year that nurses and doctors weren't 1 and 2. And engineers, as you can see, are more highly trusted than doctors. And I wonder if that is a result of the various controversies around COVID and their impact on people's trust. But right at the bottom there, of course, you've got the usual suspects. You've got your journalists, estate agents, government ministers, and polling 12%, politicians in general. And what that slide illustrates is a form of power. We, doctors, healthcare professionals of every kind, we have the one thing that politicians, the NRA, every big institution, organisation, power broker in society wants more than anything, which is the trusting ear of the public. When we say something, typically people believe us because we are doctors or nurses, whatever healthcare professional we are, and they trust us for that reason. And that is very, very important. And of course, it's also exactly why the NRA wanted to shut doctors down. So coming on to COVID now, this question, should we get involved or not? It's difficult being a doctor. It's hard enough doing the day job without speaking out. And I would never suggest that anybody has any obligation to speak out. But this is why I try to do it. If we ask ourselves why we went into healthcare, it's a really easy answer, isn't it, to that question? It's basically because we care about patients. We want to help people. We want to make a difference. We want to try and do something good and positive with our lives. It's all about helping people. Rudolf Virchow, who you will remember from his famous triad, is also, but less well known as, really a social activist. So this quote I love from Virchow about doctors being the natural attorneys of the poor, and I think this allies, or it chimes with that fundamental reason why people go into medicine, to help people. If we want to help people, we all know that there are socioeconomic gradients in health. If you're poor, you're more likely to be ill, you're more likely to get sick, you're more likely to die. So if you go into medicine to help people, then naturally you are going to be trying to work on behalf of people who don't have power in society, who don't have wealth in society, because they're the people who are more likely to be ill. And therefore, in Virchow's words, doctors are the natural attorneys of the poor. We have an opportunity, and you could argue an obligation, to try to advocate on behalf of our patients, try and speak out and do good with our words as well as our medicine. Going back to what for me was the worst phase of the pandemic, I imagine it was for lots of you in this room, and thinking about that opportunity to advocate on behalf of patients. So this period, early January 2021, the sort of peak of the second horrible wave of COVID, was a pretty wretched time for most people working in the NHS, particularly in palliative medicine. And it was a time that had been preceded by months where SAGE, the scientific advisory group advising the government, were urging them, both behind the scenes and actually publicly, to lock down, to tighten up restrictions. The Omicron variant had arrived and was going through the roof, and we were on that exponential curve again. But we were still at a phase of our domestic politics where the government was talking about saving Christmas and having Christmas bubbles. And I remember this time as just unbearably stressful, because we knew what was happening, we knew what was coming, and we were still talking about Christmas mixing. And all of those headlines you can see were exactly the result of those restrictions not coming in when they should have done. My hospital, I know a great many London hospitals were completely overwhelmed. Again, the London ambulance service was overwhelmed. They couldn't get to patients before they died in their own homes. They couldn't bring them into hospital. There weren't enough physical ambulances and paramedics. It was a really horrific time, and it's a very shocking example of the mismatch between the public narrative at that time, a denial essentially that we were in crisis, with what we as frontline healthcare professionals knew was really happening. And in this first week of January, I was asked if I wanted to appear on BBC Question Time, which I, on the one hand, did very strongly want to do, to try and tell the public what was happening, that it had to be worth trying to do that. I was also very wary of doing that. And I, without breaking any confidences, when I decided to appear on Question Time, I did so having had some very helpful behind-the-scenes conversation with some of my seniors about whether or not to do that, and there was a consensus that it would be worth doing. So I'm just going to show you a clip, which I hope will work. So this is the panel that I was on at this time, and I sat next to Nadine Zahawi, who was the then vaccines minister. And unbeknownst to Nadine Zahawi, I hadn't even been vaccinated at that point. I hadn't got a COVID vaccine, even though I was working on COVID wards. I took great delight in making that point publicly on Question Time. And strangely, the next day, my trust, and I think every trust in the country, got a very stern letter from NHS England saying that they had to immediately hurry up and vaccinate all their staff. It was unbelievable that there were staff treating COVID patients who had not been prioritised for a vaccine. Anyway, let's see if you can hear this.
Today, in the last 24 hours, over 1,000 people have lost their lives to COVID. Now, that's more than every single person who has died in Australia of COVID has done in their entire pandemic. We've lost more than the Australian death toll in 24 hours. And in hospitals at the moment, conditions are unimaginable. We have ambulances queuing up outside. Patients, we can't get them out of the ambulances into hospitals because every single bed in intensive care, in the wards, in A&E is full. Tonight, I had messages from a doctor in London to tell me that police cars are delivering critically ill COVID patients into his hospital in London because there are no ambulances. That is how bad things are. How could the government have allowed things to get so bad? Sage told the government in September to have a circuit breaker. They told the government before Christmas, you have to lock down, and Boris Johnson ignored it because he's pathologically incapable of making a difficult decision, and that is reprehensible.
So,
I didn't really like doing that, but I liked less the fact that this was happening. And I was speaking to A&E consultants in London who were telling me this was happening, and we still didn't have a national lockdown. And I felt really desperate because the one thing we all have with our patients is the patient in front of us. We can always treat the patient in front of us, and that's certainly how I got through the pandemic. I treated this patient, and then this patient, and then the next one. And even if I came home at the end of the day knowing maybe all of those patients had or were going to die, I could still try and do something good for one human being and then another. But somehow the big picture of this, you know, the words used were things like tsunami, weren't they? Just knowing that the exponential curve was crashing down on us and crucially our patients, and the decisions weren't being made that could stop that dying, I just found psychologically unbearable. And And I was lucky, in inverted commas, enough to have this platform, so at least I could try and use it. Interestingly, the price of speaking out as a doctor is not great. So I got a couple of really unpleasant phone calls the next day. One from someone very senior in the London Ambulance Service, one from someone very senior in NHS England, both of whom made their displeasure very clear. And, you know, the words, you know, would it be a good idea for them to speak to my CEO of my trust, or perhaps the GMC, about what I had done, were those threats essentially were made. And I said to the GMC threat, I said, I happen to believe in my NHS duty of candour. Nothing I've said is untrue. I think it's in the public interest for these facts to be in the public domain, so please go right ahead. Trying to be terribly brave and, you know, then put down the phone and burst into tears. Nothing happened, but it wasn't very nice. It's not just the government that tries to control the narrative in a pandemic. It's also a lot of other individuals, groups, organisations. And the rise of the anti-vaxxers in 2021 was a horrible aspect of the pandemic. And I'm just going to play you this clip from one of them. This is a nurse who's been struck off the nursing register, called Kate Shemirani. And this is a clip of her in Trafalgar Square in the middle of the summer 2021. And you'll hear her here directly threatening doctors and calling for them to face their own Nuremberg. And we all know that Nazi doctors were hanged at Nuremberg. So this is what she said in the public domain.
Ask those that are getting it. Has there been any deaths? Ask them what is in it. Ask them. Get their names. You email them to me, the medical revolutionaries at protonmail.com, with a group of lawyers. We are collating all that. Are there Nuremberg trials? The doctors and nurses stood trial. Are they on? If you are a doctor or a nurse, now is the time to get off that bus. Get off it and stand with us, the people. All around the world, they are rising.
Amazing, amazing. So around this time in summer 2021, the amount of abuse and hate and trolling that you would get on social media if you were an NHS doctor, nurse, any other kind of healthcare professional advocating COVID vaccines was absolutely incredible. I used to get death threats, rape threats, horrible abuse, to such an extent that around that time I had to get Thames Valley Police involved because I was genuinely worried about my children's safety more than my own, but I guess all of us. And they took it, I thought they'd sort of laugh at me and say, don't worry, you'll be overreacting. And they didn't. They said, yeah, we're really worried too, and we're going to put you on this special list so that if you call 999 from home, we will come instantly. Which was sort of good and yet also not good. Nothing ever happened, but this is another example of the same trait, actually, that you saw in the NRA example, and also from the threatening phone calls I got from within the medical establishment after appearing on Question Time. If someone speaks out and you don't like what they're saying, you try and threaten them. You try and bully, threaten, frighten them into keeping quiet. And that's an unpleasant trait, but it's also a reminder of how powerful the voices of doctors can be because we're trusted. Because everyone knows you go into medicine because you want to help people. That probably means you're a truthful person. I'm going to finish with a couple more quotes. I apologise, I like to share my very favourite quotes, but I think this is a really profound quote. If politics is a means of distributing power between different groups and individuals in society, then this quote, which is from the political philosopher Hannah Arendt, is very, very telling. You're not successful politically if you just use facts, numbers, statistics. So those kind of daily COVID death tolls were very shocking, but also very abstract. And after a while, the numbers almost didn't make sense anymore. Whereas, if you tell a story about a particular human being who has experienced COVID or is a member of staff, whatever it might be, but if you tell a story about somebody, that's a means of engaging emotionally, empathetically with an audience. It's a way of connecting with people, and it's very, very potent, and it can be used for malign ends, as some politicians may do, or incredibly good and important and precious ends, as I'd suggest most or everybody working in palliative care tries to do. We try and make those empathetic connections with our patients so they don't feel as alone, as frightened as they did before they walked into our consulting room. So that's a reminder of how important storytelling is, whether it is you and one patient or trying to do something on a bigger stage. And I wanted to end just with a few more headlines from this year, because this is a reminder of how the dynamics that we saw at play in the pandemic are still at play today. You read these headlines and they're almost the same as January 2021, except now we're not talking about the COVID crisis, we're talking about this year's winter crisis, the crisis that we predict, we know is happening every year, we know is avoidable. It doesn't have to be like this. If we had more staff, more beds, it wouldn't be like this, but every year it happens. And again, we have the same dynamic where there's a government narrative of there's no crisis, nothing to see here, everything's absolutely fine. So we literally had Rishi Sunak denying there was a crisis when this year's crisis really got going. And meanwhile, we have a chorus of frontline voices trying to say, no, there is a crisis. We've got people dying in ambulances, in corridors. Please help us. We want to help patients. And we're powerful voices because we're regarded as telling the truth, because we do typically tell the truth. Those 500 headlines all came from the Royal College of Emergency Medicine, who were brilliantly effective in trying to drive the narrative this January. But of course, we'll probably see the same headlines in 2024 as well. To finish, I've tried to focus on why speaking out at a public political level can be a form of doing good for patients. But I just want to end by reflecting on this. I personally find that speaking out isn't just something I feel is part of my duty as a doctor in a way, or at least a doctor who used to be a journalist. But very, very personally, for me, psychologically, I find it really difficult to feel as though my lived experience, my own testimony, what I am actually seeing every day at work, is being denied at a public level. If somebody says, no, there's no crisis, when I know that I'm having end-of-life conversations with patients on trolleys and corridors without even the dignity of a curtain around them, it feels like a twist of the knife to me. I find it very difficult to have that truth denied. I want people to know the truth. And I think to some extent we're all like that. If you know something is true because it's your life, you're living it, but someone with more power and more status and more clout in society is standing up and saying, no, that's not true, that is unbearable. And of course, Maya Angelou, she was talking about that phenomenon in relation to race in America in the 1960s, but it applies in in any scenario where somebody's story is at best not being heard, but at worst actively being suppressed and denied. So I'm not ending with any grand conclusions, and I'm certainly not suggesting you should all immediately go forth onto BBC television by any means, but I feel as though we're in this very difficult situation in medicine in general in the UK, in palliative care particularly, given the parlous state of the funding of our profession in the UK. You know, the vast majority of it comes from charities, not the NHS. We're in this really difficult situation where it's easy to feel helpless and hopeless, but we've got a voice. We haven't just got a voice, we've got the trust of the public. Most people are good, most people are decent, and most people know when someone is being dishonest or telling the truth. And so I feel there's an awful lot of scope for us to try and work on the public stage as well as just day to day with our patients in our professional lives to try and do good for patients. And I will end there and open it up to you guys. Thank you.
Thank you, Rachel. That was a really fantastic presentation and really thoughtful, Rachel. The way that you ended really strikes a chord with me at working children's palliative care, and I can really see some similarities with when we have our high-profile, challenging cases that make it into the press, often very drawn-out court cases, that actually there's no right of reply from the staff. So that feeling of that untold story inside, because there's only one side being reported on, and also lots of we already have problems with perceptions around children's palliative care, but that feeds into a lot of untruths. And I'm thinking back to the more recent one where a doctor on television said things like, well, children's hospices can't provide oxygen to children. So it's hard to watch that happening. And I sometimes want to speak out. But the thing that has always stopped me in every situation is our kind of internal politics and policies. And you refer to that. And I just wondered if you've got any advice. We try and say, but we're not going to comment on that individual case. We just want to talk about some, changing the narrative around children's palliative care. Every time I've tried, I've been shut down.
Yeah, really interesting. I'm coming to the APPM conference in November, and partly hoping to speak about exactly that issue. And I didn't want to talk about it today for that reason. But I think the cases you're describing, Alfie Evans and Charlie Gard and the Battersby case most recently, are such a horrible example of interest groups and pressure groups with a very particular agenda getting involved in a case that is fundamentally about a dying, deceased, brain dead, whatever the scenario is, child, and an absolutely heartbroken, grieving set of parents, usually, and a team who are doing their absolute utmost to act in the best interests of the patients. And of course, normally the patient and the child and the parents' views are allied and everyone's on the same side. But when that breaks down, it's just absolutely desperate. And I think I always think when these cases appear, which they do relatively frequently, my heart goes out to the team looking after the child, because I just know how hard you will be trying, working to do the best you can in that situation, and you are being vilified, not just by the pressure groups, but also in the tabloid press sometimes, and it's incredibly easy to be incredibly hurtful about a clinical team in the tabloids and just not see them as human beings at all. I ended up writing a piece about the Battersby case, very hesitantly, and I only wrote it after he died. But the reason I did that, it was for The Guardian, and they had asked me to write about it while the case was still ongoing, and I said no. But after he died, the narrative in the tabloids, and actually not just the tabloids, in all of the media, it was so badly reported, even the good health and science journals didn't understand the issues at stake. And the reason I decided to write the piece was not as a commentary on the specific case so much as the issues around what does it mean if someone is brain dead? What does it mean if you can't perform the testing that enables you to diagnose brain death? You know, these are really important issues. And I just felt as though the media was doing the population a disservice by not articulating those. And initially I just did a thread on Twitter, a very careful thread, all based on the publicly available NHS guidance and definitions. And the response to the thread was incredible. Like, thousands of people retweeted it and shared it and said, thank you for explaining this. I didn't understand this. I just didn't know what the issues were. And it was after that response from the public that I did decide to write the piece for The Guardian, because it was, what it taught me was most people want to understand. They don't want to make snap judgments. Most people get it, that this is an impossibly difficult situation, and people are trying their best. You'll always get cynical players, some of the religious groups who bankroll these grieving parents. I think it's just appalling what happens. And it's easy to think that the whole country hates you and there's nothing but vitriol for you, the clinical team, if all you're reading is sort of what you're seeing on social media or nasty newspaper headlines. And I think what I took from that Twitter response, and Twitter is a very toxic place, was, gosh, most people are not like that. Most people want to understand, and it's just that they don't voice that. The people who are vocal are always the haters and the angry people. You know, I always think of the trolls as apologies for this very sexist comment, but I always think of them as kind of middle-aged men in their dirty underpants, sitting at their laptop late at night, like, I hate you. I'm sorry for the sexism, but most people are not like that, and they want to understand. I don't know if someone from within the trust that is caring for an individual can write something like that or communicate like that because of the fact that they're within the trust. I think that's just not possible.
No, it's more when it's a child in another hospital, I think.
Yes.
When a few of us have said, well, this isn't our trust, so why don't
Yes.
we just correct some of these misconceptions around we
Yeah.
don't give morphine to kill children.
Exactly.
We provide oxygen in hospices, that type of thing. But I think the trusts are very, very, very risk averse.
Yeah. And the problem is, trust comms teams are very risk averse, typically. Not always. I mean, COVID was interesting because sometimes I would get CEOs of other trusts getting in touch with me privately to say, thank you for telling the truth. We can't. All COVID comms went through NHS England, and everybody's officially, their hands were tied. But one CEO said to me, I can't speak out, but you can as an individual, and thank you. So it's interesting sometimes, even the sort of trust comms teams and very senior trust members do want the truth to be out there. But I think when you risk creating a furore and a scandal and people demonstrating outside your hospital and spitting at your staff and all the awful stuff, you can see why protecting your trust reputation comes above sort of public education. But actually, we all should be trying to do the public education because the public want to understand by and large. There's only a few sort of bad agents.
Thank you, Rachel. COVID was probably one, if not the worst experiences of my life. And so hearing you talk about some of the genuine terrors that we were seeing day to day, it does help sort of talk through that untold story part of me when I'm sad and what I do with all of this. I wonder, how much weight do you give to the worry that maybe telling some of these stories and the true sort of horror that was there actually works against some of our aims in palliative care and demystifying and destigmatising talking about dying and dying as a scary thing?
That's a very good question. And it immediately makes me think of the assisted dying campaign. I'm not speaking about where I stand on that, that's not relevant, but I think of that because the Dying in Dignity campaign in recent years has very deliberately made a decision to highlight the horrors that can occur when the dying process is bad. And I really, really worry about that because on the one hand, I believe in candour. I think we have to tell the truth, but at the same time, it's scary enough dying to begin with without having read the sort of advertising from a pressure group that's trying to change the law that screams at you, you are going to have a horrible, brutal, undignified, racked with suffering kind of end. And I think this is really difficult because in medicine, it's not, our job is not simply lay the truth out on the table and say, here it is, you've got pancreatic cancer, so you may have a really, really horrible death. And I'm just going to put it out there and say, I wouldn't want that diagnosis myself. Obviously, that's not what we do. It's such an art, isn't it? Building a relationship with the patient and being honest, but actually timing the flow of information, working with how quickly or slowly or not at all the patient wants that, and trying to frame things in a way that maintain a degree of hope. I think, personally, there are some of the kind of comments around, in inverted commas, a good death, I think are perhaps unhelpful because they are too sanitised. So my own belief, and this is what I say explicitly to patients if they would like to have this conversation, is there are parts of dying that when you die, I think there are two kinds of suffering. There's necessary suffering and there's unnecessary suffering. So unnecessary suffering is all the stuff we can hopefully palliate. Pain, breathlessness, symptoms. Definitely did not happen in COVID for a great many patients, and many of us in this room will have had terrible experiences, but it could have been. And that was the tragedy in part, it could have been. So usually when I was involved with a patient, I could control their suffering, but the tragedy was the patients who didn't get that input for whatever reason. So I think there is this the kind of unnecessary, avoidable suffering, which if you have good palliative care, nearly always you can control. Not always, but nearly, even if you have to resort to deep continuous sedation as a last resort. I think there's always something you can do. And then there's the unavoidable form of suffering, and for me that is the kind of existential anguish that goes with your life ending, and everyone you love and everything you love in this world just slipping through your fingers. You cannot stop it happening. If you love anybody and either they are dying or you are dying, it is unbearably painful, because grief is what love turns into. The more you love someone, the more painful it is to leave them. And we can't palliate that, and we shouldn't pretend we can palliate that. Talking about it, being open about it, and supporting patients and families as they go through that, I believe is the way forward. And so I'm not sure, I sometimes worry that if we talk about a good death, and it's perfectly possible for death to be this very gentle, kind of relaxing experience, I worry that perhaps the public think that's not true. You're pretending. You're not being honest. And I try to be clear about what we can do and we can't do, because I worry about that. And I think in general, it is better to be honest, but honesty that is conveyed with kindness. So with COVID, I would be very honest and say, I know that many people died with symptoms that I dearly wish they hadn't had on a COVID ward. In theory, we could have done things differently if we have another pandemic. We would do things differently. There are ways simply to control these symptoms, but it didn't always happen. And that's the way forward, I think. Never knowingly try to pull the wool over people's eyes because you think it's kind. Does that?
Yeah, I guess there's always, because what you were doing when you were trying to draw attention is to, I suppose, say the shocking thing, because it's helpful to say the shocking thing because it gets people's attention.
Yeah.
But the worry is by saying the shocking thing, you miss that nuance.
Yeah, and you frighten people. And you know, then that was the NHS England argument. You know, we can't suggest that services are overwhelmed because it's going to frighten people. But I mean, I think that's a slightly different issue. People were right to be frightened because services were overwhelmed, and the only way to stop that happening was to make different political decisions. And I saw the cost of not doing that as greater than the cost of frightening people. And people might disagree with that, you know, it's hard. Sorry, just speak up a bit, just say that last bit again. Yeah. Yeah, so how is the current economic crisis affecting palliative care in particular? Yeah, terribly. It is the short answer. I mean, you know, we before COVID, the NHS had been through the most sustained funding squeeze of its entire history since 1948. 7 or 8 years of roughly about 1% increases in NHS funding budgets, when the national average over all of the years of the NHS was 3.4%. So not keeping up with demand, not keeping up with the ageing population and so on. That was before COVID. COVID's obviously had a catastrophic effect on the NHS. And now we're in an economic crisis where today's figures are that the UK's inflation rate at the moment is the highest in the world out of any other country in the world. So all of that is making the NHS budget, such as it is, stretch less far, and it means that the population is suffering. And you know, even simple things like if you are at home and you need oxygen and you need electricity to fund your oxygen concentrator, your bills have gone through the roof, and all of that is just disastrous. The other thing that's really difficult at the moment is the combination of the economic crisis and the long-term fallout of COVID. So the lockdowns, the fact that we had to focus almost exclusively on COVID for significant chunks of time during the pandemic means that now we're seeing later stage cancers, later stages of every disease, so really complex patients, but with a more depleted workforce than pre-COVID. And so times are really tough. I've been a doctor for 14 years, and in the hospital, it's never been as desperate as it is at the moment, and morale is rock bottom because people are despairing that it's ever going to change. And I guess all you can do is one day at a time, this patient, this patient, this patient, and if you feel like it, speak out, try and speak out as well. Yeah. And the economic crisis in terms of pay for staff is a whole other issue, and that's depleting the workforce.
Can I just follow that up? I'm not a professional, but I am an NHS campaigner. And just prior to COVID, one of our campaigns was to try and prevent the closure of an inpatient palliative care unit in London.
I know where you mean.
In fact, I'd like to see you afterwards to see should we reach the stage of calling a public meeting whether you might like to speak at it. But the story was they couldn't get a consultant, so they had to close down the inpatient beds at a very popular, and as far as I can make out, very good palliative care unit, on the basis that there are voluntary sector hospices, but some of them are terribly inaccessible from things like the borough that I happen to live in. But it's very interesting, of course, during COVID, it was repurposed as a COVID step-down ward, and they were supposed to have come out with a report. I think it's worth giving the story, because it explains how some of the NHS bureaucracy is working to put off decision making and putting off public involvement in these issues. It was closed down for a step down ward. The public, there was supposed to be the report which was going to come out over a year ago now. We are hearing it is nearing the end. Where our campaign has new people actually involved in some of the working groups, but they're excluded from some of the core areas, like what's going to happen to the single NHS units that they're going to close down. And one of the bylines has been, well, most people want to die at home, ignoring the fact that that picture changes as people get closer to death. And we're talking of an area of London which has, in particular, a large number of single women. And who does the caring? Women. So how women are supposed to, when they're older and dying, look after themselves is an issue we have to put to them. So I think there's some really interesting questions that come up, not just, that are tied in with the effects of COVID, but about also the underfunding and what's happening to provision, and how provision is behind our backs in some ways, actually being badly cut. So the palliative care provision simply isn't there for people who need it.
Yeah, absolutely, completely agree. And it's very, very difficult. I don't know if the local MP is supportive or not, or local journalists, but I think you have to try and...
We're trying.
Good.
and we've got several local councils, including Conservative councils, who have over the time supported the campaign, whether they will continue to do so. It's sort of in abeyance, and you almost feel that's a tactic as well. Why have they waited more than 12 months beyond the date that they're going to for being kind all that.
Thank you, and thank you, Rachel. If you would like to join me.
Oh, yes. Hang on a sec. I forgot to do the last slide. This is what I'm really excited about. If you want to look at the website, this is a new charity, UK charity, which I've set up with a Ukrainian doctor and Henry Marsh, who is a UK author and neurosurgeon. And this is to supply funds to local palliative care teams in Ukraine, and also we're hoping teaching and training, so a sort of online programme of teaching and training. TBC, I've been doing it all myself, so it's taking a long time. But if you are interested, if you go onto the website, the address is on there. It's just info@hospiceukraine.com, and you can read about it, and please get in touch. It's me, basically, the email address. Thank you.